Uh, we're excited to be here, as Jimmy mentioned. So I currently work as Chief AI Officer at G Healthcare, where we do a lot of AI into that goes into our devices and ecosystem, and we'll talk about some of those capabilities on the impact of AI and in places where AI can really leapfrog the devices and device capabilities in a lot of ways as well. For instance, a few years back, MR would take 30 minutes to 1 hour. Now we're talking about using AI to cut that time down to 50% or more with the same image quality. That has huge implication for a lot of downstream applications. So now you can think of a lot of patients with neurodegenerative diseases in the past who might not be able to get to that technology. They can actually get access to that. So that's one of the examples, and we'll talk more about that. But just to kind of set some of the segue, uh, so at a high level, I mean, if we have to look into some of the healthcare problems, I'm assuming I think like most of the folks here come from machine learning and a healthcare background. So some of these challenges kind of exist across the board, where 97% of the healthcare data is unutilized. And if we look into the volume of the data that's created, 30% of the world's data is healthcare data. So we're talking about a huge opportunity to use AI to actually use or leverage this data, which is actually not utilized, which can lead to a lot of inefficiencies. A lot of our focus in G healthcare goes across the spectrum of things, but if we look across, uh, if we talk to our hospitals and everyone, like burnout is the top component that comes out, and it's even more in radiologists, where 49% of the radiologists feel burnout, and that number is even more higher in some of the countries where you have ratio of one radiologist to 100K population. So how do we scale some of these technologies that can really help to address some of these challenges with inefficiency, data overload as we go across these different spectrum of things as well? So kind of give an overview at G Healthcare. It's a 130 years old company, but it's also, I would say, 1 year old company. Uh, GE Healthcare was part of a massive GE enterprise, and we've been building a lot of these capabilities. Last year, it became a separate entity, which has a lot of its exciting opportunities that kind of come across the spectrum of things. But if I look across the history, where our journey started back in 1896 with diagnostic ECG, medical imaging, patient monitoring devices that were being built out across the spectrum of things. That's something that we've been working on across for a substantial more than 100 years as we go across these different areas. Post, I would say around 2014 is when we had our first FDA approved app authorization for AI capability that was added in X-ray. And since then, deep learning across the imaging cycle has gone at 10x in a lot of ways as well. So now, and we'll talk about some of the examples of how AI is kind of integrated for better image quality that can help for better diagnosis, for cancer, for arrhythmia and other diseases as well. We're talking about how it can actually help radiologists, clinicians, technologists by providing that experience that can reduce their time they spend on device in automating and like making sure you can actually automate a lot of those mundane tasks in a lot of ways as well, and like really making sure we can then do the sub once the image is acquired, like the next steps, how are we going to measure the size of the tumor? Is that increasing with time, decreasing with time? Can we kind of semi-automate some of these capabilities? That way more focus is spent on the time to review what needs to be done out of that as well. So as we worked across this, as Jimeng talked about, today actually we have 80 plus FDA approved app authorization. So that number keeps on increasing. And as we go across these things, I think what's become important is, yes, there's a lot of capabilities that go into our devices. How are we making our MR machine, CT machine smarter? But there's also started to be more focus on enterprise-wide solutions. Like, so we have capability which is called as command center, which is deployed in 300 plus hospitals. But think of this as for nurse staff or clinicians as soon as the patient enters. How many beds are going to be free in next 6 hours, 3 hours? So kind of creating that capability that they can make decisions based on the data that they have, a lot of predictive modeling, a lot of time series capabilities, as well as combining multimodal data that comes across spectrum of things as well. A lot of capabilities on virtual care, making things as a seamless experience in hospital as well as outside of the hospital, and going over there. And today's talks and some of the theme that we'll go into is like how do we further push the boundary, and where foundation models become a key ingredient, where multimodal is also one of the key components as we go across these different spectrum of things as well. So as we talk, feel free to, if anyone has any questions, feel free to raise hand. I want to make sure it's more of a dialogue and a discussion. I'll briefly talk about some of these AI capabilities that's there, and then kind of go into how there could be a future where we can further enhance some of these capabilities. So we talked about uh, creating or building AI capabilities, but also actually into that's integrated into the workflow. So, for instance, AirRecon DL, that's our flagship technology in MR. And as I talked about earlier, like it's able to give same or better quality of image quality with 50% reduction in the time. And then that's been a huge plus for hospitals where in the past, if they would be able to go one or two patients per hour on an MR scan machine, now they can go through four patients. So that's been a huge lift in improving the workflow as well as getting more out of the devices as well. And it has so far gone through 28 million plus patients worldwide with this technology. And so think of these capabilities more as similar to with Tesla, you would see over the top upgrades. So how do we bring in like whether it's existing devices, new devices, but bringing some of these AI capabilities off the shelf, kind of making sure we can push the boundaries further. Other examples kind of go into similar directions as well. Can we get to a really high quality image, which can be used to track small size of lesion and tumor? That way you can track and make better diagnosis decisions going forward as well. Sonic DL, it helps to reduce the cardiac MR image time by 1/12 the time. So you can actually catch it in one heartbeat. So, and that again, it's again a game changer in a lot of ways because a lot of capabilities which could not be done in the past are now unlocked with these capabilities as well. The second set of capabilities are more around detection or workflow automation. So we talk about longitudinal view for the patient, but if we have to look into the medical imaging, ARX Brain kind of provides that. So a technologist would take a scan of a patient, but in next 2 months, if another technologist is taking the scan to see how a particular thing is reacting, it might not be aligned overall. So either it might require calling the patient back for rescan or making sure you can actually fit that is more tailored for the downstream application. That has huge cost as well as a challenge. So when we're talking about longitudinal view of the patient, you're getting data, even if it's longitudinal, but the data is not aligned. Sometimes image is more focused on left, sometimes it's more focused on right. This technology is automatically able to align the patient positioning, so which is quite important. So you're changing the scanner position to better align with how patient has been put in. So that way you don't have to, which is quite important because technologists could come with different experience and background. It really helps to scale that operation. Similar capability into our ultrasound. So it is used for fetal heart measurement in the brain. And even over here, what we see is across the workflow, there are a lot of clicks that they have to do to actually get measurements and other capabilities. With this automated AI component, they're able to reduce the number of clicks and time by 80%, which is a huge lift across these different setting of things as well. The next is what's called as caption guidance. So we have been these days looking a lot into co-pilot or a companion kind of experience. This is an example of that a lot in the medical imaging space. So a sonographer could come from 1 year experience or 17 years experience. How do you bring them to the same level field? So what caption help guidance does is when a sonographer is taking an ultrasound, it provides inputs. Okay, move a little left, move a little right, and now you have a diagnostic quality image, which is a huge game changer because now you're providing using AI to provide guidance in a way that becomes a learning tool as well as helps to get a consistent quality image across the spectrum of things as well. So that's again, it kind of brings out how do we bring more balance into the access side of things as we go forward as well. The last example is on segmentation, which is so this was a recently 510(k) cleared product, which is called as CT, deep learning auto segmentation algorithm, that came out last year. It's mainly used for organs at risk. So when a patient is given radiation during their oncology journey for treating it, radiologist needs to ensure that the radiation don't go to the soft tissues or organs surrounding the tumor, and it's targeted more towards the tumor as well. So they have to manually contour the organs. Okay, avoid hitting the simulation over there as well. It's a process where across the workflow, it usually takes them 3 hours to manually contour those organs and take it over there. With this technology, we are able to provide automatic segmentation. They're still in the loop where they can modify, but what we found was that 3 hour cycle is cut down to less than 20 minutes. In fact, in our subsequent follow-up studies, we found 90% of the time, radiologists actually go with the output coming from the model with no modification or minor modification. So that 20 minutes is also further cut down in a lot of ways as well. So here you're talking about the workflow, you're saving 3 hours per scan, and now they can spend more time on other things that can be more aligned for their time in a lot of ways as well. Now, talking about AI, generative AI, I think there's been a lot of emphasis. I'm sure everyone has heard about these technologies and how they're empowering some of the capabilities that are getting built out. There's a huge potential. I think, like, given how AI or deep learning has been, I mean, there's more progress in medical imaging, I would say, into integrating into the workflow than other domains within healthcare as well. But this also gives an opportunity because how this technology is built is kind of more tailored towards healthcare than anything. And I'll talk about why that is the case in the case of foundation models as well. So there's a huge potential with this technology to unlock a lot of efficiency improvements as well as reducing the overall cost, making sure the data gets properly utilized in a lot of ways as well. So as we look across these capabilities and with generative AI, there's a potential, I mean, as we look across these different numbers to potentially generate 150 to 200 billion in value in healthcare through productivity improvement. So clearly we are positioned for progress in this space. So and I think what's been exciting phase is I think like how technology has moved in last 2 years. I would say it has changed a lot of milestones. So a lot of milestones which were thought about would be taking time are coming faster. In fact, a lot of these technologies that we're talking about are coming sooner than anticipated because of the paradigm shift with the right compute, right data, and the scale of these models that are getting built out. So we're seeing a lot of these things will start to happen sooner than they were earlier anticipated in a lot of ways as well. And then just in healthcare, I mean, like if I look into last 2 months, there've been tons of innovations that are more tailored towards healthcare than anything. Like, I mean, with talking about models from GPT 4.0 with a longer context, Gemini coming out with models again with 1 million, 2 million tokens. You're talking, you can actually create a longitudinal view for the patient with this much kind of context size. You're talking about capabilities which are more tailored to do multimodal, which is yes, these technologies started as language models, but I think one thing which not a lot of people realize, I think how these technologies were built out are tailored more as multimodal capabilities. And that's where these technologies, they start with large language model, but they're going to transform medical imaging, genomics data, combining all those capabilities together to really create that multimodal capabilities and experience as well. So a lot of these things are happening, which is really accelerating the capabilities which we thought would take some years to get to that space. And as we go across that, just briefly going into the oncology side of things now into why foundation models are more relevant. So looking at a snapshot of a patient going through a breast cancer pathway. And actually it's similar, kind of similar if we go across in lung cancer, if we go into prostate and others as well. So starting from healthy screening, diagnosis, planning, treatment, and monitoring as well. if you look in as patient goes through this different disease-based workflow from screening to diagnosis to planning and treatment, uh, if you see there, they go through a lot of devices across, like for instance, in screening, they're going through ultrasound, they're going through ultrasound with biopsy, MR. Then in diagnosis, in diagnosis is MR plus biopsy, and then for tracking and kind of monitoring, you have PET spec that are used across these areas as well. So the challenge has been that the data is spread across these different steps, which is spread out in silos, which leads to a lot of problems related to, for instance, it causes because you have less context on the whole longitudinal view for the patient. It creates uneven adoption of screening, low trial enrollment, treatment selection, what are the guidelines that need to be selected for a particular patient, poor follow-ups and surveillance. So clearly, there is need for multimodal data to work for healthcare, and that not the other way around. And that's where foundation models come in. So foundation models can be thought as a key component for vertical enabler for the full life cycle for a patient care. So as we looked into the previous one, going from screening, access, diagnosis, treatment, and monitoring, so across the spectrum, but it's also a horizontal enabler. And what I mean by that is because these technologies are so adaptive, you can easily go from oncology care pathway from going from breast cancer pathway to lung, but even across different care pathways, going from oncology to neurology to cardiology, because of how these technologies are built and how they can adapt from one setting to another. For example, things like what happened to patients 2 months ago, what therapies were given to that patient. Foundation models can help answer these questions more quickly by looking at the longitudinal view, multimodal data from key checkpoints, from screening, diagnosis, treatment, and then kind of connecting the dots together as well. So this actually helps clinicians stay closer to the patient instead of having to go back and forth between their different workstations. So it's the multimodal data meets the multimodal AI. And the emergence of multimodal medical AI models actually unlocks new possibilities in healthcare. In fact, it creates a new paradigm shift in a lot of ways as well. And that becomes a good segue, a high level overview of what we mean by foundation models and how they're different. And then there's been a lot of discussions around that. I mean, if we look across the traditional pathway, across any of the tasks that were done in healthcare or in general as well, focused on one task at a time, label data, each task requiring separate model training, looking into a separate component, which leads to retraining for different settings, different hospitals, different adaptations, leading to higher cost, complexity, and slow adoption. So, in a lot of ways, the reason why healthcare hasn't penetrated enough in healthcare compared to other domains is because of some of these challenges. And with foundation models, you envision building an expansive, unlabeled data model that creates a more versatile and adaptable models, a model that can adapt to multiple things. So imagine you have one model which can do anomaly detection, anatomy segmentation, automated measurements, radiological quantifications, all with minor adaptability as well. And that becomes a key component where it helps to reduce the need for data that's required for downstream applications. A same thing can be adapted for multiple settings as well. So which kind of becomes a potential for how do we accelerate AI applications in healthcare at 10x the pace. And then this is the high level vision of like how one can think about foundation models at a high level where you have data coming from imaging, text, time series, gene sequencing. I mean, there's a huge diversity of data that comes out, and then the impact that they could have on the downstream application. So, and there's tons of areas where AI is still right at the beginning. I mean, we've looked into a lot of AI at the clinical decision support side of things, like can we do better sepsis, better predicting of mortality? Yes, those are going to be important. But there's tons of other opportunities in healthcare on improving the workflow, providing better reconstruction of the images, faster reconstruction, patient acquisition. Can we really personalize that for patient? Can we know the exact time it might take for scanning a patient? That way we can really streamline those operations. can we know about the missed care opportunities by combining social determinants of health, looking into whether the patient will miss an appointment or not. So there's a lot of opportunities across these things. And as we go across foundation models, because they can process wide array of data, so you don't need to have all of this data to begin with, but how these architectures can really shape up is how do you adapt it to multiple settings. The same technology with adapters and others can extend from text to images to video. And that's, I mean, some of the examples why we've seen rapid adoption and like enhancements of these technologies is because of like how you can easily add these different multimodal dimension of data into the workflow and really automating and refining healthcare processes in a lot of ways as well. And then that's another view of looking into healthcare, where multimodality is the new norm, where if we look into today's medical imaging AI models, often, as we talked about, it's single input modality. It could be medical imaging, clinical notes, structured data like ICD codes. However, healthcare records are inherently multimodal, which is a mix of provider notes, billing codes, lab data, vital signs, imaging, gene sequencing data, variables, and more. And that's going to continue to increase. Like you're looking into some of the recent enhancements that happen with your iWatch and others. So you're going to get more of these data from outside as well as inside as well in the hospital. So you're going to get a lot of different diversity of data. And the multimodalities, as I said, like it's only going to continue to grow. So no modality in isolation can provide the complete view of the patient's health state, but combining those can actually help accelerate a lot of those ecosystem. And that's where with foundation model we can imagine a future where here's an example on the left side, which some of the research that we did on triple negative breast cancer in patients looking into multimodal data coming from multiple signals from radiomics, pathomics, clinical pathology, and transcomics, kind of combining that. And foundation models could be utilized to build a joint representation and then can be used for downs by combining these different omics and then kind of creating these clinically explainable AI models of recurrence prediction, which is one of the ways it's done in triple negative breast cancer is using a Capri score, which gives a prognostic score, and that can be grounded with clinical knowledge as well. So there's huge potential of combining these different data sets, and you don't need to have all the data sets. You can still, even if you build a model combining these different modalities, it would work still well if you only have one set or a subset of these data sets. And that's where this flexibility becomes a key ingredient in a lot of ways as well. Here's an example of the found research on one of the foundation models we did last year. It's an ultrasound. So imagine you have a camera, you're trying to take a photo of a person. You might do one or two clicks on the camera to zoom in on that person. And once that person, you identify that person, as that person moves, you can actually track it with the video as well. So it's the same technology that you provide to the clinicians. It's called SonoSam, where imagine it's able to identify the tiniest of tumor or lesion. So they can identify that with minimal number of clicks, and they can actually track it with time as well. So as it moves across the body, you can actually track it and see how it's moving and reacting in different ways as well. Now, a lot of these technologies, I think one of the key advantages is yes, it's really promptable, it's easily able to adapt, but also I think its generalizability. Like, for instance, this model was never trained on breast lesion. So we looked into the breast care pathway. Now, imagine a model, this one already had a 90 plus dice score. So you're starting at a model which wasn't trained on breast lesion, it wasn't trained on fetal head, it still had 90 plus dice score. So for you to create a clinical application, you're starting at a 90 starting point versus 60, 50. So you can easily now think of how you take that 90 to 95 in a lot of ways as well. So I think that's where these technologies become truly transformative on building these applications really fast and adapting that for different use cases as well. Here is another example of, again, segmentation, which is it's called as Embo Assist AI, which is designed to transform the embolization workflow. So basically, you want to see when you want to actually predict and visualize the potential places where the injections need to be done to optimize your embolization strategy. So you can actually simulate that across in the three-dimensional space and see where it needs to be given, which significantly assist in standardizing the practice for robust programs as well. So I think how can you create that real time with advanced visualization and these AI capabilities with few clicks or no clicks at all? So I think that's where these technologies become really transformative in a lot of ways as well. And now grounding is becoming a really important concept in a lot of ways as well. And then the key ideas, yes, even in medical imaging, the key advantages you would have in the traditional models, you would have a lot of data, you train, iterate, and kind of even when you do transfer learning, you need some data, you iterate from that. But what if you can use, I think, to truly make these systems adaptive, it has to be language driven. So I think that's where grounding is as a key component, where it is language driven. So as generic and it can get, so you don't need to create thousands of models, which is hard to create, but at the same time maintain, but adapt based on the use case that you're trying to do. It is similar to how humans interact with systems. So shorter learning curve and better adoption. So on the right side, you can see like, hey, with some tuning, you can see, can you generate firmer right grounding in the CT? And it's able to identify just with the language based on the context, it's able to identify where it is. So the green one is the ground truth, red one is where it predicted. So you can see how close this is, and also how it can adapt with unstructured queries that can come across these different workflows as well. So imagine if anyone wants to go deeper, clinician who has just 2 minutes going into the data trying to click, but if he can ask that question more as an interactive way, they can get to the right place where they can actually focus. That's it's a huge game changer in a lot of ways as well. So a lot of these technologies are going to become super relevant as they come out across the spectrum of things as well. And then kind of adding to why foundation models, again, re-emphasizing, I think, yes, as we looked into some of the examples, they're generalizable, so easily can modify to new settings without, uh, in a lot of ways, as we saw, the model wasn't trained on a lot of those data sets, it can still adapt to that. They're easy to adapt to different tasks, which is kind of a key component, I would say, in healthcare, because a lot of time a hospital would have a particular setting where they would want to do it. Can they adapt to different settings in different ways as well? And similar to the standardization of patient level data, which we do through FHIR and other EHR APIs, making these models available through APIs significantly alter the cost structure of training these models. You can quickly adapt with some settings in some form or capacity. So there's a huge potential with these capabilities. And lastly, they're collaborative. So the same data you can summarize, you can get different view for the patient, you can get a different view for the clinician, you can get a different view for the oncologist from the same data. They can interact with that, they can interact with each other to understand it in a better way as well. And I think that's where this creates more collaboration across different systems and partners as well, across the healthcare as well, because even within the healthcare, you have different persona of users. You have nurse staff, hospital staff who are starting at the emergency, it's going at the ED level, it's going at clinician, physician, and radiologist, all the spectrum of neurologist across different spectrum of things. So how do you bring them together across the same problem that can really help bridge a lot of gaps going forward as well? So I know we are at a good time. So, but these are some of, again, some of the examples where we are seeing these technologies are becoming useful. So not just at understanding the data, but now it's also being used real time in surgery. So image guided therapy. So one of the capabilities that we looked into is, can we use these foundation models when a surgeon is doing a surgery to put a screw in the spine of the patient to get the real-time 3D simulations that can really help align in a lot of ways as well. So can we use augmented reality in interventional lab to really streamline the operation? So it's about workflow efficiency, it's about and collaboration, as well as making things easier to simulate in a lot of ways as well. You can use some of these capabilities for even like as we looked into embolization planning, which is like where the injection needs to be given for embolization. I think that becomes a key component over there. The other end of the spectrum is also it allows, like a lot of times for interventionalists, they have to look into how much of to, and for me to get a really good quality image, I need to optimize on the dose, how much it needs to be given so that I can get good contrast of the image, but these technologies can automate a lot of those things as well. So again, a lot of these technologies are adapted and can be used in a lot of these different use cases also. How do we bring them together? Because at the end, a lot of these problems are multimodal in nature, and that's where some of these technologies are rapidly getting integrated into the workflow, more than we anticipated, I would say, 5 years back in a lot of ways as well. And then these are some of the Gen AI use cases, more of a language model use cases. So that's also one of the foundation models that comes out. But like on clinical documentation, summarization, phenotyping, and intelligent clinical decision support, because you can combine multimodal data that can enable personalized diagnosis, triaging of patients, treatment planning. So you're now starting to do not just at the diagnosis level, but across the spectrum of things, better clinical trial matching with multimodal data. I think a lot of these things are getting enhanced in a lot of ways as well. And this is an example. I think this is was a collaboration with Jiming as well. So again, I mean, some of these technologies, as you combine these large models with knowledge graphs, they're truly gonna transform in a lot of ways as well. You can think of as a chatbot, like you have a lot of structured, unstructured data. How do you make it easier for different persona of users to interact with the same data? That's the first thing. But also, you might not have a lot of data. I think health, the challenge is you're not going to get a lot of data even at the patient level. So how do you really streamline these models with minimal amount of data that's needed and ask these general VQA questions over the multimodal data, which could be EHR data, it could be EHR plus imaging as well. And then as we saw, I think combining these personalized knowledge graphs with language models offers significant advantage. And you can envision in the future by making these systems more interactive, where you can really reduce length of stay, which is a really important metrics where hospitals look into that, because they want to optimize that. That way you can know or be well informed on how they can triage future patients coming in as well. And then as I think in the paper as well, I mean, all of this was done with 0.1% of the label data. So there's a huge impact from that perspective as these things and capabilities get brought into the ecosystem as well. So next, I'll give an example of, again, large language model, but more in the perinatal space. So when nurse staff is actually looking, as well as clinicians are looking into the patient during the labor, there are a lot of protocols, a lot of these questions that come out as well. So, and this data guidelines keep on adapting, changing as well. So how do we bring in some of these things by using these large models, which are multimodal in nature? So you can ask simple questions like, for instance, you can ask question over here like, my patient failed their initial sepsis screen. What should I do? So it's the as you can see, it's a question. It can interact. Okay, these are the guidelines that comes outside of that, and then creating a summary out of that as well, which is more intuitive and can be really streamlined. So over there, every minute counts, and a process which would have taken them 10 minutes could be done in 30 seconds by getting a more streamlined view of this data as well. So that's where I think these technologies become super interesting and exciting as well. And then lastly, I think like just to talk about, I think responsible AI piece. I think as one of the key ingredients of bringing these technologies is how do we use and build them out in a more responsible manner as well. And then in that case as well, I think a lot of these technologies are made or tailored for that. I think because you can really streamline them with minimal amount of data. So a lot of concerns around like data privacy and security kind of take into account. Explainability of these models, I think that's a really important thing. Making them transparent, explain why those components are coming in. And lastly, trustworthiness, I would say. I mean, like uh, and then that's where at GE Healthcare, when we say about those 80 FDA approved app authorizations, any of those algorithms, as we looked into Air Condial, it's gone through 28 million patients, so across the world. So what it means is like, even as they're built out, like building a model is usually 10 to 20% of the time. Most of the time goes into multi-site validation, where you want to make sure this model is robust enough that can work across multiple sites with different demographics and settings. And that's something that creates more trust as we bring in some of these technologies as well. So I think that becomes an important artifact of how these technologies are really going to shape. And same with foundation models in generative AI, we need to bring in that same rigor as we go across as well. So with that, I'll take a pause. Happy to answer any questions at this point. Thanks, everyone.
Thanks, Perry, for the very comprehensive talk about the foundation models use cases. So next up, if you have questions, feel free to type in the chat. While we're waiting your input, I can start ask some question that our team have already had for you, Perry. I guess first question, I want to hear your perspective in terms of the evolution of this foundation model, kind of the as you shown in one of the slide, right? In the past, right, those individual tasks require individual models. Then the single models that can generalize to answer many different questions seems to be a breakthrough, right? That's where large language model bring in. And then later on, people start looking at building a specialized LM or foundation model for specialized domain or tasks, and then maybe using different agents to coordinate them together. So how do you see this evolution of foundation model? Do you think this single model will be like a super smart model that will be the answer for everything, or you think in we still need many different models for different purposes. They have to work together. What's your perspective on the?
Yeah, 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 definitely. And actually, I didn't have a slide on that on the evolution, but as you called out, I think like we started with single purpose models and then models which could do different things, and then with these large models coming in, and but to your point, like even with these large language models or foundation models, they're going to solve a particular thing or a problem. Uh, I think what the next phase is like, because in a healthcare setting, it's a complex environment where there are going to be multiple systems that are going to be interacting with each other. So it will those agentic frameworks become really important in that space where different tasks, okay, there's one agent which is looking into only at the guidelines. For instance, if you're looking to, there's one agent that's only looking into the changes that's happening onto the pathology side of things. There's one agent that's looking just into the radiomic side. And then there's a master agent, imagine, that's looking across and monitoring those signals across those systems as well. So now the question might come, how is this different than, okay, if you're building 100 models, which if we want to do today, it's the adaptability. Because at the core, yes, while they are functioning different things, but at the base, the model is still same, right? So you're using one or very few models, but they're getting adapted for different settings and things as well. So I think that's where the paradigm is changing in a lot of ways as well, where you would still have multiple models interacting with each other, but they come from one or very few models. B, they can quickly adapt with time as well. So I think like a lot of these systems become even more relevant is because I think while we are seeing this alignment and other things, but what it tells is like they can adapt based on a particular site without having to redeploy the model altogether in its. So that becomes a really important component because now you're talking about these systems which are built out, but now with the trust, that a common question that you hear from customers is that, okay, you built out a model, it has 85% accuracy at a particular place, but tell me the accuracy at my site. So you can easily adapt that model for a particular site and it can continuously learn. I think the key is going to be this continuous learning piece. We talk about Apple iPhone, right? Like every 3 weeks, we see a update coming into our Apple device. When we talk about any of these AI algorithms, there's a huge cycle in healthcare, even if we have to go through the update for any of these models. So how can you quickly adapt? So I think ML ops is going to become a key component where you create an agentic framework, but then having a feedback loop that can continuously iterate and improve and provide that high level feedback. And that feedback can be personalized as well. It can be at a hospital side, it can be more at an enterprise side as well. So I think that's where it becomes a really important capability as well.
Yeah, this is very interesting perspective. Maybe iterate between our questions and some question in the chat. There's one question in the chat that seems a very, very interesting. It's talk about the Many ultrasound are watched by patients in real time. Is there a desire to make a automatic labeling to be able to in lay language for patients to understand? And so that's can you comment on how like this AI technology being used for
Yeah.
patients versus for support clinicians, right? What's your thoughts on
Yeah.
that?
Super. Thanks for the question, and it's quite relevant in a lot of ways as well. I think where as we looked into this example as well, right? Like nurse staff is going through a complex triage of capability that goes through a lot of steps and hoops as well. Now, if you look into the response for this one, it was created in a very layman terms as well, but you can really modify that, and I think that's where a lot of emphasis on explainability becomes important, and that's one of the areas where even we invest quite a bit is like how do we make not just the output but output in a term which is more insightful and can provide insights on those capabilities as well. What the example I gave in the beginning of caption help, it does same thing, like it's an intuitive capability. It gives actually red, yellow, green signal. Okay, if a sonographer is moving it, so they can see now I can get a diagnostic quality cardiology image. So that's where some of these technologies. So providing these nudges and creating more explainability is a key component in a lot of ways as well. And I think how these technologies are getting shaped up, you're going to see a lot more of that intuitiveness as these things get rolled out as well.
Do you think the barrier for deploying like patient consumer facing type of AI solution for healthcare is more of a on the liability like type of compliance side? Like, yeah, I can see this can be probably more useful for if a patient can see this, but at the same time, there may be all the corner cases, right? Then people, there's hallucinations sometimes. The AI response is wrong, right? That can cause a lot of harm. Was that the concern why face clinician facing app it's more today's kind of the roadmap versus patient facing apps?
I think it's the users who are interacting with the device. I think for them, but being able to provide that high level overview of what those entail, that way they have more trust. But to your point, at the end, the user, like these things are built to make sure it's safe and can be used for the patients in a lot of ways as well. So I think that becomes an important. I think the clinical decision support is another concept. Like you would want to ensure clinicians have all the insights from the data that comes out, but that interpretation and those cape components that you would want to have them kind of provided to the patients in a lot of ways as well. So I think that's where it becomes, yes, compliance becomes an important piece, but at the end these technologies are enablers to help clinicians, physicians to make those informed decisions faster. So think of this as if I'm providing a multimodal Google search in real time, that's how I would think of these capabilities. Right now, the challenge is information overload. So physicians, clinicians have to go through thousands of guidelines to provide that. If you can provide that right data to them in a seamless way, then they can take the even downstream step in a really fast manner as well. So I think that's the first focus. But long term, yes, as these things get more intuitive, you could see similar capabilities coming out in a lot of ways as well.
So I think there's a lot of question. Maybe I try to connect some of the questions so you can answer them together. So on our end, we want you to comment on your perspective on open source models, right? There are those big proprietary model like OpenAI or Anthropic have trained and offer, but there's Llamas, that's an example from Meta that's kind of open source. What's your perspective on that? And then the related question in the chat is there's talking about this compliance framework, like maybe there's some legal laws kind of lead to one versus the other, right? This EU AI Act.
Yeah.
Uh, so that can affect some of this
Yeah.
consideration.
Yeah. So, thanks for the questions. Yeah, I think it's great to have both the options in play. which is open source models, which are pushing the boundaries, as well as some of them which are managed services. So depending on the use case with security and others, where it becomes a bound over there, but they're getting really close in a lot of ways as well. But I think key component with all of these is that's one aspect of foundation models. Like most of them are large language models, right? Like some of them are starting to get to multimodal, but none of them are EHR foundation models. None of them are medical imaging foundation models in some form. MedGemini kind of goes into some of those aspects, starts to go into that direction. And I think that's where it becomes an interesting aspect in a lot of ways as well. For instance, you would leverage some of the open source or managed ones in some of them, but I think some of them will require specialization in some form or capacity as well. Like when we did the SonoSam, the idea was, yes, how do we make it off the shelf models didn't work for ultrasound images. In fact, they were quite bad. Because these models are trained on a lot of things, a lot of cases. So how do you make them tailored for healthcare in some settings? I think that's going to be important. In language, you're seeing more of acceptance, like they do can align in some form or capacity. So it's going to be a combination of those things. How do you leverage them? How you build things on top of that? I think it's more the value add is the applications, and in my opinion, like whether you're using an open source or you're using a model, any of these foundation models which are through API, I think the differentiation happens more into the application that gets built out. So I think this does gives us important opportunities, like where you want to kind of align on. Like a lot of folks would be focusing on building these platform or these foundation models, but also like how do you use them and bring some of these technologies really faster to the market as well. So I think it's a balance of those. Now, on the second question, yes, I think that's a really important. So when you touched upon this responsible AI, it becomes even more important. So I think like at G Healthcare, given we have been going through 510K FD clearance for more than a decade, I think that becomes a good segue of like how some of these capabilities, and it's aligned, I think, in a lot of ways with what's coming out from EU Act. Like what they're asking is has the model gone through, has enough explainability? Are they looking into robustness? Like it's not just at a particular site. Are you looking at multiple sites for validating and evaluating these technologies? So I think a lot of these things that come in EU Act are aligned from are in the direction of how healthcare can be more streamlined and create more trust in a lot of ways as well. So I think those are actually some good ways to really shape them and provide inputs on how they can really help accelerate that ecosystem as well.
So I want to ask you about the training data. So
Mhm.
obviously that's a lot of people think about the knowledge and the capability of those foundation model largely depends on the rich and training data they have used to train those models. In healthcare, I mean, even in the general domain, there's a lot of concern or argument in terms of IP and the copyright and all those stuff. I guess in the healthcare domain, there's additional privacy, HIPAA compliant, like all those sensitivity associated with medical data. What's your viewpoint of using medical data as a training data for those foundation model, right? Or how do you ensure or get access to diverse data while maintain privacy and all the other concerns?
Yeah, I think all of them have to go through all compliance procedures, like de-identification. Like we need to scale up the operations on human in the loop, de-identification, having good tooling across the value chain on bringing these things. I think there's been significant effort on downstream. Okay, if I have data or if I don't have, but the first piece, like how do you really ensure the data can be uh, de-identified in a manner that it should be and make it more kind of robust from that setting. That's one piece. The other is also on I think multimodality data augmentation techniques as well, right? And I think that's where a lot of these capabilities become important as well. How do you create uh, the data capabilities which are going to be with synthetic or data augmentation? For instance, even if you get data from different sites, there's no way you can cover everything across. I'll just give an example. Let's say if you're building a model on X-ray, even if you get thousands of examples, there will still be some variation from the real world, and that's where robustness becomes important. Like maybe a real patient might have a metal artifact in their bone when the scan is taken, but in the training data, it's not there, right? So you can do a lot of these data augmentation, style transfer techniques that go across as well. So I think that that also becomes an important artifact into looking into these technologies. How do you bring in those components without having to kind of making sure you can actually scale to that data? So some aspect is data, making sure there are good guardrails around that. I think that's important. And then also looking into these different techniques that can really help scale a lot of these capabilities going forward. But the good thing is, I think some of the technologies that are coming out are kind of helping shape those components as well. So more and more work that gets happen, I think that's going to help scale as well. Third piece is like you don't need to have, yes, you need to have certain amount of data, but in our some of the research work which we have done, which we call as system foundation model, we've done a lot of, like in medical imaging, transfer from natural images. So we've taken natural images and kind of gotten it into an image space where case space where we try to align how is this image similar to an image that might come from a CT image or an X-ray image as well, and you adapt those images as well. So there's a lot of innovations that can happen even on those data side of things, using leveraging natural data and then translating into other areas as well.
Thanks. I noticed we just have a few more minutes. I always ask this question towards the end. We can still answer some other question if we have time. That is, we have a lot of grad students in the webinar, and your experience is quite unique, right? You started in the academic setting in grad school, studied computer science, then work at a big tech company at Amazon for several years, then come to healthcare like device company today. I mean, how does this journey shape your perspective in the AI and in healthcare? And what advice would you give to computer science, let's say grad students today, if they're considering a career path in AI for healthcare?
Yeah, I think so. There are two aspects of research that becomes important. I would say working on one is like horizontal long-term impact research. The other is working on problems which are really hard, as well as looking to solve problems which are kind of happening in real world. So as I transition to industry, working backwards from any problem, and then over there looking into not just being state of the art, but beating state of the art, and that's where innovation comes in. The first product that I had was Comprehend Medical. At the end, it's a NER system, which is name entity recognition in unstructured text. But if I look into it, like there was a lot of innovation that we did and really transformed the journey. So you can start at a problem, because that's where like a lot of unstructured clinical notes were. I mean, it still exists, but 10 years back, I mean, that was one of the key things. So you start from the problem, you talk to customer needs, and then try to map it. So one way to map is, okay, I have my research. How do I map to a problem? But think from the other way around. Okay, this is a problem, and now how do I apply my skills and research to solve that problem? So I think that's where a lot of it helps you to a better align your research, as well as to see more impact of those capabilities as well. So research driven through the problems, I think that that really helps to translate and scale a lot of these capabilities.
So what do you say to there's a lot of students in the grad school may have the feeling that, oh, if I do something abstract and theoretical, then that give me more options, right? And I can apply that in all domains, right? If I pick work on AI for healthcare today, maybe when I graduate, I mean, I want to join a different industry, then that this path like kind of narrow my options. What's your response to that type of
I think it's a mix in a lot of ways, because I think healthcare, it's an area which is a lot in need because of the challenges. Like there is healthcare is one of the very, if you we talk about multimodal, healthcare is truly multimodal. So if you want to solve a multimodal problem, it's there. Data challenges, data scarcity. So that's where, I mean, the challenges create innovation in a lot of ways as well. So you can bring that lot of those capabilities as well. So as I worked across those areas, the impact that you could make was substantial. Now you could always look for a horizontal shift. So last 2 years, I was doing more foundation models, more like Chat GPT for 2 years, 2 to 3 years at Bedrock. That gave me that depth as well because that was some of the technology. But as I built those technologies with my group, it kind of came back that, hey, as I've learned these skills, maybe there is no better time to get back into healthcare. So I started in the healthcare, worked in some other domain, learned that horizontal skill, and then got back into healthcare because I think you could see the impact of these capabilities as well. So I think that becomes important, finding a good research group that's working on these problems. And in some cases where you are asked to do a lot of these research problems, I think that also becomes like collaboration. It's a different capability. Like in a lot of times when we come from academia, like how do you create? Because at the end, you're trying to solve a problem. For that, it's possible it might not be just you, but you work with two other scientists to solve that problem together faster in a lot of ways as well. So I think creating that collaboration and solving those problems, I think that becomes a really important direction to look into that. So that requires some alignment, that maybe I might be the second, third order, I might not be the first one, but that gives you that holistic view. You need to look at the overall problem. And while in some of the problems you might be second, third, like some contribution, but that gives you the overall experience of these things as well. And then I think like in healthcare, just in general, like and even the next talk is multimodal. There's no area I think that you'll see more multimodal problems that than it's in healthcare. So, and we are just scratching the surface. So I think from potential and opportunity side, there's a lot of ways in which we can work on it. And anyone who's worked in healthcare, I mean, as I've worked on it, like I've had opportunities across the board as well. So because we have worked on really challenging problems, there's a lot of opportunities for folks who would be happy to have you because of the hard problems that you would have worked on in healthcare as well.
Okay, perfect. Thank you. I know you have a busy day or busy week, so I don't want to take more of your time. Thank you for giving this wonderful talk and share your experience and perspective on AI for healthcare. Eric, thank you.
Thanks, everyone. And yeah, I have my email if anyone has any questions. I'm happy to answer. Thanks, everyone, for your time. Thanks.
Thank you. Bye.